Hello, my name is William Middleton. I'm a professor of radiology at the Mallinckrodt Institute of Radiology at the Washington University in St. Louis. Today I'm going to present a lecture entitled Basic Aspects of Renal and Adrenal Ultrasound. Okay, so let's start with the normal characteristics of the kidney. Normal renal size centers at about 11 centimeters, plus or minus 2 centimeters, so the range is from about 9 to 13 centimeters. The echogenicity is compared to the liver on the right and the spleen on the left, and the right kidney should be equal or slightly less echogenic than the liver. The left kidney should be significantly less echogenic than the spleen. The renal parenchyma can be divided into the renal cortex and the pyramids are slightly less echogenic than the cortex, although you don't always see the pyramids. Notice on the image in the upper right-hand corner, that's a high-resolution view of a renal transplant, and you can see the location of the hyperechoic pyramids with respect to the slightly urine-distended calyces. The renal sinus is composed of fat and fibrous tissue, as well as the vessels and lymphatics, and it is hyperechoic and is centered in the center portion of the kidney. And then the outer margin of the kidney should be smooth. Now, the most common indication for renal sonography is in patients with acute renal failure to exclude hydronephrosis. Now, in the general population, the yield of finding hydronephrosis in this clinical situation is only about 1%. And unfortunately, false positives are relatively frequent. So even when patients don't have renal obstruction, mild hydronephrosis is seen. Now, the yield of sonography increases significantly if you only look at high-risk patients. And those are patients that are postoperative from abdominal surgery, have a history or physical examination findings consistent with a pelvic mass, have a history of kidney stones, etc. The diagnosis of hydronephrosis is made when there is anechoic fluid separating the renal sinus. In almost all situations, the renal collecting system will be displayed as several dilated infundibuli that are connecting to the renal pelvis centrally and connecting to renal calyces within the periphery of the kidney. And this should be seen on both transverse and on longitudinal planes. If you only see it on the longitudinal plane, but not on the transverse plane, it's probably not real. Hydronephrosis can be graded in several categories. Grade 0 is considered normal. Grade 1 is where the collecting system is just barely distended and barely abnormal, but the kidney is otherwise within normal limits. Grade 2 is a collecting system that's clearly abnormal, but the surrounding renal cortex is well preserved. Grade 3 is when the collecting system is clearly abnormal and dilated and the cortex is thinned. Now, hydronephrosis most of the time is due to obstruction, but that's not always the case. You can have a patient that has hydronephrosis, but the kidney is not obstructed. And unfortunately, the corollary is also true. You can have obstruction without having hydronephrosis. And there's a couple of ways to sort this out, or at least to help to sort this out. One is to check arterial blood flow by measuring resistive indices in the intrarenal arteries. If the resistive index is unilaterally elevated on the side of suspicion, then obstruction is likely. And the cutoff value for an elevated resistive index is 0.7, or asymmetry between the two sides of greater than 0.1. If the resistive indices are elevated bilaterally, that doesn't help you in looking at the suspected side of obstruction. And if the resistive indices are normal, that also doesn't help you in either excluding or making the diagnosis of obstruction. This is an example here that's being displayed where the grayscale image shows clear-cut hydronephrosis and dilatation of the proximal ureter. When you look at the resistive index of the questionable kidney, it's 0.76, and when compared to the contralateral kidney, which was 0.60. So clearly there's asymmetry in the resistive indices, and the resistive index on the right side is abnormal, and this was a kidney that was obstructed by a ureteral stone. Now, another way to get indirect evidence about the presence or absence of obstruction is to look at the flow of urine out of the ureters and into the bladder. If the ureteral jets are absent on one side, that means that side is likely obstructed. If there is a low-level continuous flow of urine out of the one side, then that also likely indicates obstruction. Now, the advantage that ureteral jets have over resistive index measurements is that they're affected immediately when obstruction occurs, and they resolve immediately when obstruction is relieved. The disadvantage is that you have to scan through the bladder for 5 minutes in order to make sure that the ureteral jets are clearly absent. And you also have to have a difference in the density of the urine that's exiting the ureter and the urine that's residing within the urinary bladder. So here's another example where you can see mild separation, very mild hydronephrosis in that longitudinal view of the kidney. When you look at the resistive indices, the right kidney had a resistive index of 0.71, the left had a RI of 0.57. So that would indicate that that kidney, although only showing mild hydronephrosis, probably is obstruction. When we looked at the urinary bladder, we saw that there was a detectable ureteral jet coming from the left ureteral orifice. Over a span of 5 minutes, we never saw a jet from the left, and that also suspects or makes you suspicious of obstruction. And very close analysis of that distal ureteral orifice showed a stone in that distal ureter. Now let's move on from obstruction and talk about kidney masses. The most common kidney mass is simple cyst, the frequency of which increases with age, and by the time you reach 50 years, you have about a 50% chance of having a kidney cyst. Ultrasound is clearly the most accurate way of evaluating cystic lesions in the kidney, and it's especially useful when an indeterminate mass is seen on a CT or MR or a urogram where a cyst is highly suspected. The ultrasound criteria for diagnosing a simple cyst is the lumen should be anechoic, the back wall should be well defined, there should be posterior acoustic enhancement, and there should be no measurable wall, all of which are satisfied on the image displayed. Now, what can look like a cyst but not actually be a cyst? There's a number of things. Lymphoma is a solid tumor, but unfortunately it can look like a cyst because it's very homogeneous and generates few reflections. Fortunately, this doesn't happen very often, but this is an example of anechoic lymphoma. Calyceal diverticuli can mimic cysts, arterial venous fistulas can mimic cysts, and aneurysms and pseudoaneurysms can mimic cysts. This is a pseudoaneurysm that looks very much like a simple cyst, but on Doppler analysis, you can see that it has readily detectable internal blood flow. Now, what about cysts that aren't simple, in particular cysts that are hemorrhagic? Well, initially, when a cyst undergoes hemorrhage, it will have a solid appearance as shown here. Often will be heterogeneous, but will appear solid. Now, over time, that cyst and the clot within the cyst starts to lyse, and the cyst becomes more complex, evolving into a lesion that may be cystic with solid elements or cystic with thick septations. Now, eventually, the cyst will, a hemorrhagic cyst will completely liquefy and may have diffuse low-level echoes, as shown in this image, or may have a fluid cellular layer, as shown in this image. But if you wait long enough, and this may take a matter of several weeks or months, cysts will usually convert back to a simple appearance. Now, in general, we think about cysts as occurring in the cortex, but there is a subpopulation of cysts that occur in the peripelvic region. These are felt to be lymphatic in origin. They're usually solitary, but it's not uncommon for them to be multiple, as in this example. And they can be bilateral. When they become quite numerous, they can simulate hydro, as we see in these two examples. The difference between multiple peripelvic cysts and hydronephrosis is that with hydronephrosis, you can almost always see a distended pelvis extending continuously into an upper and lower pole infundibulum and many times into a mid-pole infundibulum. And with peripelvic cysts, you see separate cystic structures that do not communicate. Polycystic disease is a disease that affects the kidneys more than any other organ, although the liver is often affected. The pancreas is very rarely, but occasionally affected. And you can get cystic lesions in the vasculature of the CNS, in particular cerebral aneurysms. Up to 10% of patients that have end-stage renal disease in North America and Europe have this because of polycystic disease. Survival is approximately 10 years on average if it's untreated. By the time patients reach the age of 60, they will usually have renal failure. It's an autosomal dominant disease, but up to 50% of patients will not have affected family members, either because of variable expression of the gene or due to spontaneous mutation. So don't be surprised if you see this on a sonogram and there's no history of family disease. Type 1 polycystic disease is the most common, and it presents earlier and is more severe than type 2 and is easier to diagnose. The signs and symptoms of polycystic disease are listed there on the left. When you're trying to make the diagnosis in a patient at risk, i.e. a patient who has an affected family member, the criteria are below the age of 30, you have to see 2 cysts in one kidney or 1 cyst in each kidney. Between the age of 30 and 60 years, you have to see at least 2 cysts in each kidney. And over the age of 60, you need to see at least 4 cysts in each kidney. Now realize these criteria will only be applicable to patients who are at risk, patients who have affected family members. If you applied these criteria to the general population, you'd be diagnosing polycystic disease much too frequently. And these are some various examples of polycystic disease and various stages of severity. Because there are so many cysts in patients with polycystic disease, it is not uncommon to get crystalline deposits within the cysts. And when that happens, you'll see ring down artifacts such as this. It's also not uncommon to have cysts that have hemorrhaged. So you'll see cysts that look solid and will ultimately go through the evolution that I described earlier. But polycystic disease does not have an increased risk of cancer, so these solid appearing lesions are almost always hemorrhagic cysts and not tumors. Now, polycystic disease is different from acquired cystic disease. Acquired cystic disease occurs in dialysis patients and generally occurs in a high percentage that have been dialyzed for over 3 years. The cysts are variably sized and they almost always occur in small echogenic kidneys. This upper right-hand image shows multiple cysts in a kidney that measures only 7.6 centimeters in size. Now, if the cysts become very numerous, then the kidney may actually become enlarged, as we see in this lower left-hand image. And in those situations, it can be difficult to distinguish this condition from polycystic kidneys. Now, unlike polycystic kidneys, acquired cystic disease does have an increased risk of tumors, and if you see a solid appearing mass like this, you have to be very concerned about a renal cell carcinoma, as was the case in this particular patient. Another complication that these patients get is retroperitoneal hemorrhage. Von Hippel-Lindau disease is another abnormality that presents with abnormalities in multiple different organ systems, but in the kidneys, it produces multiple bilateral cysts and multiple bilateral tumors. The tumors may be solid, as is seen in this example. They may be complex, as is seen here, or they can be predominantly cystic with little solid nodules, as is seen in this intraoperative scan. Now, we've kind of alluded to renal cell cancer that occurs in particular conditions. Let's just talk about renal cell cancer by itself. It's the most common solid renal mass, accounts for 90% of all renal malignancies. Risk factors include advanced age, smoking, and as we mentioned, von Hippel-Lindau disease and dialysis. It's most often detected incidentally nowadays, and traditionally it has been treated with radical nephrectomy, although nowadays there's a big increase in the number of laparoscopic procedures that are being done and the number of partial nephrectomies and ablative therapies that are being performed for renal cell cancer. Sonographically, 50% of renal cell cancers are hyperechoic to the cortex. About 10% are similar to renal sinus fat. In other words, they're markedly hyperechoic to the cortex, and this is particularly common in small renal cell cancers. 30% are isoechoic, 10% are hypoechoic, 5% are predominantly cystic, although many renal cell cancers have some cystic components, and then 10% contain calcification. And here's a collage of various renal cell cancers. A hyperechoic cancer here that looks very similar to an angiomyolipoma, and we'll discuss that in a minute. A hyperechoic lesion that's just slightly more echogenic than the renal cortex. An isoechoic lesion, a hypoechoic lesion, a complex cystic lesion, and then a lesion that is, contains some stippled internal calcification. Now, one unique thing that renal cell carcinoma does is it will invade the renal vein, as we see here. Now, renal vein tumor thrombus differs from bland thrombus in that it has tumor vascularity to it. And many times, although not always, you'll be able to detect that internal vascularity on color Doppler or power Doppler techniques, as we see here. Now, eventually, that renal vein thrombus may extend into the inferior vena cava, as we see in this transverse view, and it may extend well into the cava, and sometimes even above the diaphragm and into the heart, as we see here. Transitional cell carcinoma is much less common than renal cell carcinoma, but it is the most common urothelial cancer. The rest of urothelial-based cancers are squamous cells. 10% of transitional cell cancers are metachronous or synchronous, and it occurs much more frequently in the bladder than the renal pelvis, and more often in the renal pelvis than in the ureter. Now, ultrasound is not sensitive in detecting transitional cell carcinoma in the kidney, ureter, or renal pelvis, better in the bladder. When it is seen, it's often seen as a solid mass centered in the renal sinus, or as shown in this image, focal eccentric urothelial thickening, seen here in the upper pole of this kidney, or thickening of the renal pelvis, as seen in this transverse view. Now, metastases also occur in the kidneys, and in fact, in autopsy series, they're seen in up to 20% of patients dying from cancer. But most of the time, they're small and they're not imageable. When they can be seen, they're often infiltrative, and they're frequently and almost always solid. They can be single, multiple, unilateral, or bilateral. So the appearance, unfortunately, overlaps with that of primary renal cell cancer. So in a patient that has an extrarenal cancer, when you see a renal mass, you have to consider metastases. And since metastases will not require nephrectomy, and renal cell cancer will require nephrectomy, biopsies are appropriate in this situation. These are examples of renal cell metastases: a small lesion with a hyperechoic halo on the left, and an isoechoic lesion that was seen really only on Doppler techniques as an area of decreased vascularity in the kidney. Lymphoma also affects the kidney, usually in the setting of widespread disease elsewhere in the body. Non-Hodgkin's disease is much more common in the kidney than Hodgkin's disease. It's very rarely symptomatic. On sonography, it typically appears as a solid, hypoechoic, multifocal bilateral process. Less often, it's unifocal and unilateral, or diffuse and infiltrative. As we mentioned earlier, it rarely is anechoic and can simulate a cyst. And one unique thing about lymphoma is that it can infiltrate the perinephric region, and in those situations, it also looks very hypoechoic and can simulate perinephric fluid. Again, since lymphoma does not require a nephrectomy, and it overlaps in its appearance with renal cell cancer, if you are faced with that differential diagnosis, it is appropriate to do a biopsy to distinguish those two. These are different examples of lymphoma. This is an enlarged kidney that is just slightly lumpy, bumpy, although it's hard to discern discrete lesions. This is a lesion with multiple hypoechoic masses. This is a lesion with a solitary unilateral isoechoic mass. And then here's another patient that has several lesions that are anechoic and look at least somewhat like renal cysts. And these are 4 different examples of perinephric infiltration of lymphoma that look very similar to perinephric fluid collections. So just keep that in mind when you're faced with that appearance. Angiomyolipoma is a benign renal tumor that's composed of vessels, muscle, and fat. It's the most common benign tumor. It tends to occur in middle-aged women and in patients with tuberous sclerosis. It has no malignant potential, so if the diagnosis can be made reliably, the patient does not have to have surgery unless the tumor gets to be big. And beyond 4 centimeters in diameter, these tumors tend to bleed, and sometimes they'll be removed just prophylactically to avoid bleeding complications. 80% of angiomyolipomas are homogeneous and very echogenic. 20 to 30% will attenuate the sound beam, and that's another thing that's unique to, or almost unique to, angiomyolipomas. Our approach to suspected angiomyolipomas is to do periodic ultrasound follow-up if they're less than 1 centimeter, and to do CT or MRI if they're larger. CT and MRI are pretty reliable in confirming the presence of fat in small or in larger angiomyolipomas. It's more difficult with the smaller lesions. And here's a typical angiomyolipoma. You can see a very echogenic solid mass in the cortex of the kidney. Now on this conventional view, we don't see any sound attenuation from that lesion, but when you look with a high resolution linear array, as shown on the right, you can see some attenuation of the sound deep to that lesion. Oncocytomas are another benign renal neoplasm that account for about 5% of all renal tumors. The appearance overlaps that with renal cell carcinoma, and as you can see in the two images on the right, those are very nonspecific solid renal masses that look for all the world like renal cell carcinomas, but when these were resected, they were found to be oncocytomas. Now occasionally you'll see a central scar on a contrast-enhanced CT or MRI, or if you do contrast ultrasound, you can see it on a contrast ultrasound as well. But in general, these lesions can't be distinguished from renal cell carcinoma, so they're treated surgically just like renal cells are. The last tumor that I'll discuss is a multilocular cystic nephroma. This also is a benign tumor that tends to occur in young boys and older women. They appear as masses with multiple variable-sized, non-communicating cystic elements, as shown on the two examples on the right. Unfortunately, the appearance of multilocular cystic nephroma overlaps with the appearance of cystic renal cell carcinoma and Wilms tumors. So these lesions are also treated surgically, just like renal cells, because we can't tell the difference. Now, there are a few things that are non-neoplastic that can appear mass-like on sonography, and one is pyelonephritis. Pyelonephritis typically, if it doesn't have a normal ultrasound appearance, will appear as renal enlargement with focal cortical changes. Now, these are often wedge-shaped, not always. They can be either hyperechoic or hypoechoic, and unlike other organs where inflammatory lesions are hypervascular, in the kidney, infection causes decreased vascularity. Urothelial thickening can also be a sign of pyelonephritis, but occasionally you'll get focal masses, as we see in the two images on the right, that will look for all the world like a renal neoplasm, but will turn out to be inflammatory in nature. And those often have to be correlated clinically and sometimes need to be biopsied to prove that they truly are inflammatory. Renal abscesses are another inflammatory condition that can simulate the appearance of a cystic renal cell carcinoma. They, like renal cell carcinoma, can appear as complex cystic masses, and to make the diagnosis, you really need to correlate with the clinical history and, again, aspirate the lesion and see what you get for further evaluation. So just in summary, renal masses often have characteristic ultrasound features, but like all modalities, there's a fair amount of overlap in the ultrasound appearance of both benign and malignant and non-neoplastic renal masses. So ultrasound should be viewed as complementary to CT and MR when evaluating renal masses, and it's especially valuable in evaluating cystic lesions. Now, I also need to discuss renal stones. We no longer do ultrasound as often for evaluating patients with suspected stones, but you can see stones with sonography and you should become familiar with the appearance. They really appear similar regardless of the type of stone. Whether or not you see them depends on how large they are. And stones that are 5 millimeters or smaller get progressively harder to see. On the other hand, stones that are 5 millimeters or larger are seen fairly reliably. And they all appear as hyperechoic lesions, most of the time with an associated shadow, and oftentimes with a twinkle artifact. So this is your hyperechoic lesion with a shadow. This is a large staghorn calculus that appears hyperechoic with shadowing. And here's a twinkle artifact on color Doppler seen from a very small stone that was difficult to detect with grayscale. Now, realize that renal stones are more difficult to detect than gallstones. Gallstones, ultrasound is fantastic. Renal stones, ultrasound is much more limited. That's the reason that we do non-contrast CT to identify renal stones nowadays. Now, another type of calcification in the kidney is medullary nephrocalcinosis. This occurs most frequently in patients with hyperparathyroidism, renal tubular acidosis, and medullary sponge disease. This causes increased echogenicity to the renal pyramids, as you see in the first two images below. And it tends to start in the periphery of the pyramids and then progress into the central aspects of the pyramids. As the calcification becomes more progressive, you'll start to see shadowing associated with these hyperechoic pyramids, as you see on the third image. Now, ultrasound is very sensitive in detecting medullary nephrocalcinosis, which is a little strange given that it's got limitations in detecting renal stones. But medullary nephrocalcinosis is seen very easily with sonography, probably as well or perhaps even a little bit better than seen on CT. Okay, now I want to shift gears a little bit and talk about renal Doppler, and first talk about renal arterial Doppler, specifically renal arterial Doppler for the detection of renal artery stenosis. There's a variety of criteria that have been established. These are the ones that I rely on most heavily. One is on color Doppler imaging, detection of focal flow abnormalities that include focal aliasing of the Doppler signal and focal vibration of the perivascular tissues around the stenotic site. Measurement of the waveform velocities is also very helpful, and the cutoff value for renal artery stenosis is a peak systolic velocity in the main renal artery greater than 200 centimeters per second, or an elevation of the ratio between the renal artery and the aorta, the renal to aortic ratio, or RAR, greater than 3.5. And here's some examples. In the upper left is an example of focal aliasing, where you see this abrupt color conversion in the proximal left renal artery. Upper right, you see this focal tissue vibration manifests as extravascular colored dots, equally distributed between red and blue in the areas around the right renal artery. The lower left is a patient with elevated peak systolic velocity of 327 centimeters per second, secondary to stenosis. And in the lower right is a patient that has a borderline elevated peak systolic velocity in the proximal right renal artery of 213 centimeters per second. But when you compare that to the velocity in the aorta, you see that the renal to aortic ratio is slightly greater than 5, meaning that this is very likely to be a significant renal artery stenosis. Now, there are limitations in renal arterial Doppler, and these include poor visibility of the artery secondary to a variety of causes, but most frequently obesity, bowel gas, and shortness of breath. Sometimes the Doppler angle is very limited, and you can't measure velocities at a Doppler angle greater than 60 degrees. Extensive arterial calcification can cause enough shadowing that you just can't evaluate certain segments of the renal artery. Cardiac arrhythmias can affect your Doppler waveform. Fibromuscular dysplasia and distal atherosclerotic lesions are more difficult to detect because they're not in the proximal renal artery. Accessory renal arteries are common and difficult to detect with sonography. Even in the best patients, examination times are relatively lengthy, and it's important to remember that even at the best that we can do, we don't detect stenoses less than 60% diameter narrowing. We don't even try to. We're really focusing on detecting stenoses that are significant, and those are the ones that are greater than 60 to 70% narrowing. So how do we get around some of these limitations in looking at the main renal arteries? Well, one is to look at the intrarenal arteries. Significant stenosis in the proximal main renal artery will cause parvus tardus effects in the distal renal arteries, in the arteries within the kidney themselves. And parvus tardus refers to decreased systolic amplitude and slowed systolic acceleration. And there's a variety of ways that we can identify parvus tardus effects. The schematic that's showing in the upper right-hand corner shows a normal renal arterial Doppler with a very rapid systolic upstroke and a sharp early systolic peak. With proximal stenosis, the distal waveforms start to look like this. You lose that early systolic peak, and the early systolic acceleration starts to decrease. And then with progressive stenosis, the systolic peak gets progressively blunted, the acceleration diminishes, and that early systolic peak gets very rounded. So what do we use to quantify this? Well, in addition to looking for loss of that early sharp systolic peak, we can quantify it by measuring the early systolic acceleration. And that's done by looking at the upslope of early systole. Now, in the image in the upper right-hand corner from the left kidney, you can see that the slope, which is the early systolic acceleration, is 92 centimeters per second squared. That's extremely low compared to the right kidney, where it's 1,806 centimeters per second squared, which is much faster. Now, you don't really need to measure the slope in this case, because you can just look at the waveforms and see how different the systolic acceleration is in the left kidney compared to the right kidney. But in borderline cases, measurement of that early systolic acceleration can be handy. Now, what are the limitations of intrarenal arterial analysis? Well, many people, including myself, feel that it's less sensitive to borderline stenosis than main renal artery analysis. It does not distinguish occlusion with collaterals from a high-grade stenosis. It doesn't localize the stenosis to proximal, mid, or distal renal artery. And in fact, you can get changes if the stenosis is in the aorta or in the aortic valve. Sometimes the cursor location for measuring the early systolic acceleration is questionable, and all of it is dependent on having compliant vessels, which is not always the case, especially in elderly patients with significant intrarenal atherosclerosis. Okay, now let's change gears and talk about renal vein thrombosis. This is something else that we sometimes try to detect with renal Doppler. Realize that this requires a combination of both grayscale findings and Doppler findings. You can miss it on grayscale if you just rely on that. You can miss it on color Doppler if you just rely on that. Now, in the right renal vein, we have a fairly high sensitivity because it's a short vessel and you've got that nice big liver to scan through. The left renal vein sensitivity is lower because the vein is longer, there's more of it to evaluate, and you don't have as good an acoustic window. It's important to realize that with even total renal vein thrombosis, it still is not uncommon to have venous flow in the hilum of the kidney, so you can't just take views of the kidney, see venous flow in the kidney, and exclude the diagnosis. You really need to see the entire renal vein to get a full examination. And also realize that arterial flow into the kidney is usually not affected or only minimally affected in native kidneys that have renal vein thrombosis. Now, on the other hand, in renal transplants, the arterial flow is affected to a much larger degree, and you get that to and fro pattern. So here's an example where you can see renal vein thrombosis in the left renal vein of the native left kidney, both on grayscale and Doppler. And this image on the right is an example of a renal transplant with renal vein thrombosis where you can see that to and fro waveform pattern within the supplying renal artery. We use Doppler to diagnose pseudoaneurysms. Those occur secondary to trauma from biopsies, trauma from penetrating trauma from gunshot wounds or knife wounds, and occasionally from infection. They occur most commonly in renal transplants because renal transplants get biopsied more frequently than native kidneys. They can be a source of hematuria. As we mentioned earlier, they can appear as simple cysts, as we see here, but they'll have internal blood flow, as you see on the Doppler image. The to and fro pattern in the neck of a pseudoaneurysm that you commonly see in pseudoaneurysm in the groin is much more difficult to diagnose in renal pseudoaneurysms, but occasionally you can see it, as we see here. And remember that they can coexist with arterial venous fistulas. Which brings us to arterial venous fistulas. The etiology is similar to pseudoaneurysm. They typically are self-limiting, but they can cause persistent hematuria. Now, generally, there's no grayscale findings for AV fistulas, but on Doppler analysis, you'll see a prominent artery with high velocity and a low resistive index. So on this image obtained in diastole, you see one vessel heading into the lower pole and no vessels anyplace else. That's because there was some underlying renal parenchymal disease in this transplant kidney. In systole, you continue to see that one prominent artery heading to the lower pole. Now you see another artery heading to the mid-pole here, but look at the difference in color saturation. You can tell that that artery that's heading to the lower pole has a lot more blood flow in it, and that's confirmed when you do Doppler analysis to the artery that's supplying the fistula, gangbusters arterial flow and a lot of diastolic flow compared to the artery going to the rest of the renal cortex, which has much less flow. Now, in addition to differences in the arterial flow, you can see arterialization and disordered flow in the draining vein, and typically you'll see fairly extensive and dramatic tissue vibration around the area of the fistula. Well, that does it for the kidneys. I want to just briefly review the adrenal gland. We often ignore the adrenal gland when we're doing sonography of the abdomen, and that's probably appropriate because ultrasound is certainly not a mainline test for looking at the adrenal glands. The normal adrenal glands are difficult to evaluate, easier on the right side than the left side, but even on the right side it can be tough. These are some examples of normal adrenals on the right side. Typically you'll see them as just little linear hyperechoic bands of tissue between the liver and the crus of the diaphragm near the vena cava. And occasionally, if you're lucky, you'll see the Y-shaped appearance of the adrenal gland. Now, adrenal masses are also more difficult to detect than on CT, but in the right adrenal, masses, if you pay attention, can be seen with fair sensitivity. Much more difficult on the left side. Unfortunately, the sonographic appearance of masses is usually very nonspecific, and you have to rely on a combination of detection of mass on sonography and clinical history. Clinical history can be very helpful, but many times you need to get follow-up laboratory values, and often we'll need to further evaluate these patients with CT or MRI. So just a few adrenal lesions that you can see with sonography. One is the adrenal cyst. Simple adrenal cysts are very uncommon, but they do get encountered occasionally. And you see this one here in the liver, which is a low attenuation lesion. Looks a lot like a cyst, could potentially be a low attenuation adrenal adenoma, but on sonography it clearly has appearance of a cyst. So those are usually pretty easy to diagnose. Adrenal adenomas, on the other hand, are very common tumors. They're usually non-functional. They're usually small. 3 centimeters is a reasonable number to remember. And they typically are solid and homogeneous. And these are 3 different examples of adrenal adenomas that have been seen on sonography. And they all have a fairly typical, although nonspecific appearance. Adrenal metastases are also relatively common. It's the 4th most common organ that develops metastatic disease. And on ultrasound, again, the appearance is nonspecific, but they're usually larger than adenomas, and they're often heterogeneous in appearance, as we see in this transverse and longitudinal view of a patient with metastasis from lung cancer. Adrenal pheochromocytomas are the 10% tumor. That's because 10% are malignant, 10% are extraadrenal, 10% are bilateral, and 10% occur in patients with multiple endocrine neoplasia syndromes. They typically present with hypertension, headaches, tachycardia, anxiety, palpitations. They can be seen with sonography, but again, they have a nonspecific appearance. They're usually solid, usually large, heterogeneous, and hypervascular, as we see in this example of a left adrenal adenoma in the left para-aortic region. Myelolipomas are a benign tumor that's usually asymptomatic. They contain hematopoietic elements and fatty elements. They're variable in size, but they usually contain some hyperechoic component because of the fatty elements within the lesion. And that's what we're seeing on these 2 examples of a patient with a relatively typical myelolipoma. So when you encounter a lesion like this, a CT scan or an MRI should be obtained to confirm the presence of fat. And then the final adrenal lesion is the adrenal cortical carcinoma. These are rare. They usually occur in the elderly. They're usually large, and they usually present with symptoms of some sort. 10% will be hyperfunctioning, and usually that produces Cushing's syndrome. On imaging, they often will have necrotic areas, will have hemorrhagic areas, and calcification is not uncommon. And like renal cell cancers, they can invade the adrenal vein and then go on into the inferior vena cava. Here's an example of a large mass that has invaded the inferior vena cava, consistent with an adrenal cortical carcinoma. So that concludes this whirlwind tour of the kidneys and the adrenal glands. Please recognize that this is a very basic introductory review of the topic. If you really want to start doing renal and adrenal sonography and do it well, I'd advise you to go and review some chapters that are specifically focused on these 2 areas. Thank you very much.